Good morning and welcome to the 2023 Within Health Summit. My name is Jamie Singletary. I am the Director of Clinical Brand Development for Within Health, and I will be your host for this session. Before we get started, I did want to go over just a few housekeeping things. The session that you are going to attend today is a CE session. So in order to make sure that you receive your CE certificate, we are going to ask that you check your CE Go dashboard, okay? If you signed in with a different email address or from a different device than what you registered, we will be happy to make sure that you get your CE certificate. These sessions are being recorded, so the recordings will be available within 24 hours of the session. Also, I wanted to make note that we do have the ability, we are very excited to share that we have the ability to offer CMEs. So if there are any medical doctors that are looking for credit or need to get credit, I am going to put my email in the chat so that you can email me and we can make sure that you have your certificate. Without further ado, it is my pleasure to introduce my friends and my colleagues, Mary Dye, who is the Nutrition Director for Prosperity Eating Disorders and Wellness Center, and Dr. Sean Riebel, who is the Chief Nutrition Officer for Within Health. And they are going to present to you today on Science Amidst Stigma, carving new lines in setting and supporting recovery weight goals. I'll turn it over to you two. Thank you.
Thank you so much, Jamie. It's so wonderful to see you, and it's so wonderful to have everybody joining us today. It's Mary's and my pleasure to be here with y'all, and we're looking forward to having some great conversation. And just to start us off, I want to let y'all know how we're going to be doing this is going to be, it's going to be a typical, like I say typical, but presentations type of format. We do have some slides and stuff, but both Mary and I are going to be hopping in throughout the presentation, just because I think we both hold some passionate thoughts about this and some experiences that we have, and we want to be able to make sure that we're getting, we want to make sure that this time is well spent, that everybody hears every perspective and is able to really take something away with that. So without further ado, I'm going to start sharing my screen, and we'll dive into it here. So here we go. So well, actually, before we get into that, I just wanted to provide a quick overview just of, so carving new lines. When we think of that, we might have different ideas of what that means, but both Mary and I, as we were prepping for this, as we were discussing, like, hey, how are we going to talk about this specific topic with setting weight goals and even just the conversations about weight, both Mary and I have a love of the ocean, and specifically love of surfing. And so specifically when you surf, you're carving lines. So what that means is as you're going up and down a wave, if you're doing the things, as you want to say, as you're surfing, you're carving new lines. And so that's where that comes from. So just wanted to provide a little context of where that comes from. We're not necessarily trying to do something radical or like new and like carving this, like, yeah, I know I'm using the word new, but y'all, it's back to the basics. Back to the basics. That's what I'll leave it at right here. So we'll dive in. So what brings us here? Mary, do you want to chime in on this one?
Yeah, so I'll just also say off of that, with our love of the ocean, I think a lot of the planning of this came from discussions that we were having, both respectively looking at our parts of the Atlantic Ocean. But it really takes us back to the basics of having faith that we know what we know, and we know what recovery looks like. We know what we want our clients to experience in full and true and meaningful recovery. And so acknowledging that in Sean and my roles in our careers, we have had the great privilege of supervising, directing, overseeing many, many teams of dietitians specifically. And working alongside them. And even when we do our own case consultations or attend our own supervisions, what comes up time and time again is a couple main themes that tend to actually cause a lot of confusion and distress to us and to our people that we're working with. And those are, number one, target weight setting. What does that look like? How do we do it? What's the best practice? And when our clients maybe they've met that and likely are continuing to gain sometimes well past that initial, and we start getting some pressures maybe from the client, from the team, maybe some self-doubt comes up of what's going on here. And so we really wanted to use this chance, since it tends to be the two things that Sean and I talk most about together when we're consulting with one another and collaborating. And so we wanted to kind of bring our conversations about it, dive into the research, and bring it to this space. So that's where we are. So we have a chaos slide.
So a chaos slide, and I know I advanced it a little earlier than expected, but the thing is like there's a lot that's going on when we're talking about these different points of assessment. And specifically, this slide really speaks to, I think, what we see as clinicians and practitioners. There's a lot of noise. There's a lot of noise going on. We have a lot of different acronyms. We have a lot of different themes and terms and whatnot. You can see ideal, recovery, healthy, target, biological. There's all these different things that we have running through our heads, and we're trying to figure out where we land. Anything, Mary, anything else you want to hit on for this one?
I want to say that also, whether my clients are coming or going from various treatment center settings, working with different providers, I feel like everyone has their own language. I feel like I just talked to 5 people in the last week who were all in treatment settings that used a different acronym for what they were going to call weight. And some were given targets, some it was disclosed to them, some it wasn't, some were given, one number. Some were feeling terrified because there was this word overshoot happening, buffer weights, all of that. So just kind of giving a minute to go, gosh, this is really hard when we're amidst all these different systems and just names for this thing that's at the base here.
And then in addition to that, though, as well, there's a lot of noise that happens within not only the team, and just, I know everybody on the team, within team, you might be looking at these and being like, oh my goodness, I was chosen. You were one of the ones. So hello to our within teammates, and thank you guys for participating, even though you didn't know you were participating.
Yeah, who have all done this work and really understand why we set targets the way we do. But we did put your little snapshots up here with some thought bubbles.
Yes, we do. And just full disclosure, this is not what these teammates have said. We'll be clear
not at all.
Not at all. These are things that Mary and I were talking about. But I think this slide encapsulates, kind of shows a visual of what's happening when you think of with this whole thing with weight, the weight talk or recovery, when we're talking about nutrition rehabilitation. Something that Mary brought up while we were planning this was just how important it is to see, like, look at all this noise that's happening around the client. And then also too, with the dietitian specifically, how we're holding on to a lot of these different comments, these different thoughts, these different attitudes, these things that are happening. And also in addition to even like our own internal bias, that's something that we need to be aware of as well. But you could see around here, you could see, okay, well, if someone's weight restoring, there might be someone on the team. What about heart disease? Like what's going on? What's happening here? You could see other ones. Well, okay, can I start swimming yet? I've been eating so much more. I can eat more than all my coworkers at lunch. It's embarrassing. Like what's going on here? We need you to get back to soccer already. Okay, if we weight restore them anymore, they're going to relapse. So we're holding.
I hear that all the time.
Yeah.
All the time.
Yeah. Mary, please chime in here with this.
Well, I just want to say, I think that, whoever is saying these, and again, it's not what these faces have said, but whoever's saying these things, we firmly believe has the client's best interest at heart, right? And we're all really trying to find recovery for that person to kind of help them navigate it. And I think everyone's biggest fear is that they're not, going to find that lasting recovery, that a relapse is going to happen, or that we're going to like overly stress them. And so much of that stress comes from this idea of, well, maybe they're reporting this, really high struggle with body image here. How am I ever going to see them, through to this other space? So we're going to get more into that a little bit later. But I just, I know when Sean put this slide together, I just felt so like validated in that I feel like myself and the dietitians I work alongside, gosh, we have been in so many meetings where this is what comes. And I can have so much compassion for everyone voicing their concern about the client's well-being. And then here's that client in the middle, and they're feeling all of it, whether it's being said directly to them or they're picking up on those little kind of nuanced suggestions or whatever. And so I really see us, and I feel like I'm speaking to everyone who works in this realm, but particularly to my eating disorder dietitians, because I just want to acknowledge how much we hold in this place of really feeling as if we want to help, protect and sort of bubble wrap the client to these pushbacks. But we also need to help these team members, family members, loved ones, whoever it may be, ourselves, understand, this person is in this acute state of distress and their eating disorder. That's what's right in front of us. And we want to acknowledge all of their concerns and not just brush them off, because I know we truly do believe that everyone's really voicing genuine concerns for the clients. But we've got to really dig deep and help everyone feel secure in trusting the body, because how's the client ever going to have a chance of trusting their own body when they're living already in a world of weight stigma, weight bias? That's going to be hard enough to recover through, no matter, where they are in this weight spectrum. But when they're feeling it from the people who care about them and are on their team, they're interpreting it in different ways. I really feel that the eating disorder dietitian really has to help that client to understand where, if they're hearing these concerns, they might be coming from, and help the other members of the team understand why we are advocating for that body to be able to go to whatever weight is necessary for that individual recovery.
Yeah. And so that leads us into, where are we going today? What's the roadmap? What are we looking at? So specifically, what we're hoping that you guys can walk away with today is explaining 2 common practices used to set weight goals, and specifically in eating disorder treatment. One physiological mechanism that's at play during the nutrition rehabilitation process, and then also how to actually talk confidently about recovery weight goals to clients, support systems, and our care team members themselves. Because as we know, we are more than just the team that we might be acutely working with. We know that clients might be going to other providers, and so we want to be able to explain and justify why we believe what we do about someone's weight there. Okay. So diving into as we know, in eating disorder care, there are many different methods for setting weights. You guys might be, some of y'all that are attending here today might think of 3 or 4, like right off the top of your mind. And so we know that we have growth charts for younger individuals. We have ideal body weights. We have those things that have been used by insurance and BMI, and then we have set points, and if you think of that chaos slide, right? Like expected body weight. We have all those things that we can use to project where we think someone might be. And there are things like with that, but ultimately, and I know this is like what, I think people might be really jazzed up about finding out, like, okay, so what is it? Like, what's the way to do it? And I want to be clear, like that, here we're going to be talking about those things, and you're going to get those answers specifically. And when you look at it, it's back to the BMI. It's just BMI. and then I know some people might be like, what, are you kidding? Like, what's going on?
We're as disappointed as everyone with this.
Yeah, we were too with that. But if you go to the API guidelines, and why the APA guidelines? Because we know that that's one of our practice guidelines that we do have. And we know that there's not a lot of guidelines out there for us. So we go to what we have. What do we specifically have? You could see it here in recommendation 1C. It's in statement 6, height, weight, and BMI. Right. And you see how it gets broken down a little bit with that. Then again, it's not necessarily, it's in there too, physical appearance, including signs of malnutrition or purging behaviors. Right. So that does help us get a bit more subjective with things, but there is still that objectivity there. Right. And I don't mean to disappoint, but it is what it is right there. That's something that we do need to understand. It doesn't mean that we need to be happy about it, but it does mean, okay, wait, how can we use this as, again, and Mary and I were talking about this, and Mary uses the metaphor of it's thrown the first dart, gives you that starting point, right? It's not everything.
Yeah. I think to me, it also, as disappointing as the literature is, that it all comes back to citing BMI, that I hope we're speaking to a choir that we can mostly agree that it is incredibly flawed and not at all like numbers we really want to ultimately going by. it helps me understand when I'm talking to various team members, particularly on the medical end, where they might be coming from. It helps me have compassion for, wow, this is really deep in the literature and it's really flawed. And like, how can I use this in a conversation and then as like a jumping point to where do we really need to get bodies? And so I do want to say here, since like BMI is on our screen a lot here, and it might be bringing up lots of things for different ones of us in working with that calculation. Thinking just like Sean said, it's just the initial throw the dart if we have nowhere else to go, and we're talking restoration goals for clients that are already, coming into treatment without a particular focus on a weight restoration. It's also telling us, and we'll kind of speak to more later, we're never going to go down. We're never going to put a goal down, like lowering a weight number or BMI, because we absolutely, without a doubt, come from the belief that recovery cannot happen if any restriction or any goal of declining weight is a part of it. It just cannot. So that kind of blasts a lot of, I think, when we read these recommendations about setting things according to BMI, I know that's a reaction that has come up for Sean and myself is, wait a minute, this like takes out a lot of clients. So just saying we're never going to downshoot, but when we need to have an upper target, we can use it as a starting point.
Nice. And specifically, and I wanted to talk a bit about BMI and from the point of almost association ideal body weight. We know that BMI doesn't account for body composition. We know that those with the same BMI can have varying body compositions, and body composition is determined by someone's sex, someone's age, someone's race, their muscularity. There are many different factors there. It can be useful for populations, but not necessarily for the individual. So that's the thing that I think we need to take away from that. When you think of even with adolescents and children, you're looking at specifically their height and weight growth velocity. You're looking at how much they're growing over time or how much things change. So there's this great study by Frostad and colleagues that was published. I forgot the specific date, the month, but it was back in 2022. And this is something that us at Within, we really were happy to see this, because they did this review of, my goodness, I forgot how many articles it was totally that they found, but it got narrowed down to about 19 articles, and it included over 1,300 patients in there, and their ages were from 11 to 73. And so they looked specifically at outcomes, like what were the major predictors of relapse and where were the higher risks of relapse happening. And what they found was that all studies supported that the lower BMI, either close to or within the normal range at the end of treatment, was disadvantageous, leading to a higher risk of relapse. And I wanted to just bring that back, because while we do say that BMI is something that is available, it's that starting point. But the thing is too, is those constructed BMI categories aren't something that we are going to be using as a determinant of someone's recovery. Specifically, when you look at the literature, I mean, even when this article, majority of the articles were prospective observational studies, and when they were looking at it, a lot of the cutoffs were for like that quote unquote normal body weight. When it was at the lower end of that normal range, that's where recovery was defined for some of these. But when they were looking at it, they found that actually when they dove into the more specifics, they saw that individuals were actually more successful at the higher ends of that BMI range. So that's something that I did want to highlight here when we're talking about this. So specifically though, Mary, did you want to jump in on something? I feel like
I was just gonna say to kind of broaden that, in that literature that was talking about people that are going into this specifically with at lower body weights that are needing to weight restore, looking at getting them up to these. We know that through cycles of weight cycling and just lived experiences through the eating disorder, many coming in are going to be at body weights that are not in those zones of the BMI. So I just wanted to kind of bring that in, if that's what that study was talking to.
Mm-hmm. Nice, cool. So what do we use then? Specifically, what do we use? And so when you look at what we have available, one of the most widely, I shouldn't say widely because not everybody might be familiar with it, but you could see in the bottom right corner, you see Heron and Larkin. And so they've done some work, and they wrote a book called Nutrition Counseling in Eating Disorders. And specifically, they term this biologically appropriate weight as this area of that can be this all-encompassing endpoint. And I don't like using that word endpoint, but it's that place where we could say, okay, where do we see people being really successful in that recovery space? Okay, and you could see I put it the Academy of Nutrition, the Academy of Eating Disorders, because that's within this, the nutrition guidebook as well. But what we're looking for at this weight is specifically absence of restricting or dieting, binging, or obsessive compulsive or compensatory exercising. And specifically when we mean of that, eating disorder behaviors, right? Outwardly or covertly, however you want to look at that there. But it's also going to be supportive of normal growth and development, as well as psychological function and physical function. So when you think of GI distress and things like that, and I know that could be a little controversial. I'm not going to say that recovery leads to, abated GI symptoms. We know that that's not necessarily the case, but we do know that there are physiological mechanisms at play when someone is not getting enough nourishment specifically. But also to this biological appropriate weight is also consistent with their where their body was landing before any onset of eating disorder symptoms, as well as their gender, ethnicity, and their family history. And we'll get into that a little bit as well. So because when we're talking about biological appropriate weight, and again, you guys might hear this as target body weight or expected body weight, but when we talk about biological appropriate weight, this is what we mean, what you see on this slide here, okay? So what Mary and I were thinking while doing this was we wanted something practical. And this is something that actually Dr. Oliver Pyatt and I were talking about over months, and people on the nutrition team, we've been speaking about it, but we wanted to have a takeaway that we can use. And I want to fully acknowledge that this weight history piece in the middle there, the proportions are a little different there than the other boxes or circles or shapes. And that's intentional. That's really intentional because, like Mary mentioned before, when we start with our initial assessment, when we're looking at someone when they come into our doors or come to get care, yes, we have the growth charts that we're going to look at. We're going to look at growth trajectories. We're going to look at BMI and ideal body weight, and we're going to use those as that starting point. Again, it's the trailhead. That's the trailhead for deeper conversations, and specifically weight history. When we started today, I mentioned that the foundation was going back to the basics, and that's what this is all about. Typically what I've experienced, and y'all might have experienced some anxiety around this as well, is you have a client coming in and it's, okay, give me this information so I can just get your meal plan started. Get going, let's start. Okay, new behavior change, right? Like that's what Mary and I always talk about, where, vehicles for behavior change, like that's what we got to do, right? And I want to encourage us to slow down and really work on that weight history as well, because that is such an important factor of what lies ahead for this client. It's going to determine their risk of relapse or not. Like Mary was saying before, if we're setting these goals too low, we're setting someone up for failure. So we have to be clear about expectations, and we need to be clear about expectations with ourselves as well. So for any of the, go ahead, Mary. Yeah.
I want to add one thing, because I was just actually wrapping up an assessment on a client, and it's so interesting. And I don't know if non-dietitians out there watching this might not have experienced this, but in a general nutrition assessment, it asks us up front for the target weight we're going for. And this is a lot to do with like insurance and, knowing how far a client is from their goal, or justifying why we're advocating for them to stay or, go above a place that, insurance frankly might want. So we're asked to give this target like from day one. And a lot of times in our team meetings, we're asked that on day one or week one of our client. And we don't know the whole history. It's such a catch-22, because, where do we go when I haven't had time to really fully assess the weight history, to really assess where is my client in state? I don't know where I'm at. I'm shooting these these arrows, like Sean was saying. So we really just want to encourage everyone to take the time to invest in a full and thorough weight history. And I am notorious from leaving like lots of text in my target weight things with lots of disclaimers about how I'm going to like reset it a million times throughout treatment. And frankly, that does get a lot of pushback. But I think it's really important to give stock that this isn't like a one-off. The other piece I want to say here, and I really like that this weight history is so much bigger visually on here, is when we are first meeting that client, as Sean said, we're so on it, like, all right, let's get a meal plan started. Let's just start making little changes. Let's set that target and all. And sometimes perhaps in the idea of like easing or soothing our client into this and helping them to be like, oh, no, it's okay. We're just like going here or whatever. We're, sometimes a little bit colluding with the eating disorder. So we got to check ourselves on that. But we have the opportunity from day one, meeting clients, meeting the larger team, meeting the family, the caregivers, everyone on this team there to support the client, of making it very clear that any weight that we're shooting for is just a baseline kind of best approximation of a starting point that we're going to go forward from. Just like we might be more comfortable using the phrasing around meal plans of like, this is like initial meal plan and there will be bumps or increases or movement along the way to reach goals. I think we've got to get so much more comfortable just as a discipline of just saying, this is like an initial and it's up for reset constantly as we're evaluating. And I won't lie, that's a really hard sell when you're doing UR reviews and your client might be covered based on their weight trajectory, their percentage, advancing or whatever from those weight goals. So I think we've got to really be prepared as dietitians to really push for our strong reassessments as we get more information on weight history.
Yeah.
That's what I had to say.
No, I love it. And it's super helpful and such a great point too, because and I was laughing what you were mentioning, I was laughing internally about like the asterisks, because that's specifically what we have in our documentation as well when we're setting, when we're sharing ideal body weight. Yes, we know that that's not something we're necessarily going to be looking at, but it is information. And there's that asterisk. Okay, hey, we know that there are some limitations with this. And also with biological appropriate weight, hey, this is what this considers here as well. So y'all that are on the screen that are clinicians and practitioners, these are things that you can talk through yourself as you're going through the assessment with a client. Okay, what was your highest and lowest weight at your current height? When was the eating disorder onset? I'm not going to read through each of these, but there are some that I really do want to focus on, specifically when you look at weight during early and late teens and weight during early 20s and each decade thereafter. We have to look at circumstances. We have to say, okay, what was going on with the family? Were there any family disruptors going on there? And I know that might sound a little elementary, but what I mean by that is, okay, where's the family unit? Where's the family system? Were there, adoptions? Was there death? Was there people moving, changing jobs, things like that? Okay. Additionally, social, you can look at that as many different aspects as well. Okay, where was someone's social connection? Who did they have? Who were they relying on? Economically, what's going on? Activity levels. When you think of injuries and health, you need to consider, okay, was this something that has been historically chronic in this person's life? Or is this something that came on because of the eating disorder? We can't ignore that as well. And specifically environmental as well. We know that built environment for individuals can be something that isn't necessarily the most conducive to recovery in every way possible. And I mean that in all ways possible there. So I wanted to just spend some time on this because y'all, when we're meeting with clients, when clinicians are meeting with clients, like these are the things we need to consider. We need to take the time to go over these. So, cool.
Yep. And so that pretty diagram just lands you at your jumping off point because I will say I have very, very rarely ever met someone who really reaches their full recovery at that initial weight target. It just doesn't. And with our clients that are coming in at higher body weights, helping them to get comfortable with, no, weight loss is not part of this. yes, it's actually quite likely that weight is going to go up here. And that's okay, because your body needs to heal. So this is where kind of the fun begins. So once that initial target is met, I mean, I talk to clients about, all right, I feel like we're getting out of the deep, dark woods, but that's all we are, is out of the deep, dark woods. Now we've got to really see, where are the behaviors? We're going to get into talking about state assessments. But really, this was just our like initial. So hopefully at this point, we've achieved medical stability and we're out of the woods in a lot of way. But hey, brace for pushback, because this is when insurance is wanting to cut their, saying goals have been met. We very likely have those little thought bubbles from before really coming in. I know just the other day I had, a family saying, oh, we've gone ahead and taken that snack out because obviously, like, she's ready for that. Well, actually, no, not at all. So we don't want to take our foot off the gas at this point. And I just want to really hold space for all of you on teams or family members, those parents that really know their kid is not back yet. Really trusting your gut of continuing to go forward, because you probably have some clear indicators that we are not yet in a space of recovery. So whatever your vantage point is, we want people to get so comfortable sharing with everyone else involved. Hey, I am that, maybe I'm the sibling of this person. And I know that we used to watch movies together and you would eat popcorn with me and you still don't. We're not there yet, right? I'm your dietitian and I'm doing a cooking exposure with you and you're still being super, super cautious in every move and really looking kind of with those deer in the headlights eyes when I bring you in. I'm in the trench with you in this and you're not there yet. So really being confident in you're seeing what you're seeing. I don't care what the paper or the chart or whatever says about where this person's weight is, but we've got to have full recovery when we have effective, appropriate lengths of stay, time with providers, family members, that can really support that full healing. So not being afraid to really advocate for full healing. And when Sean and I were kind of talking through this slide, we kind of agreed, like, gosh, how many times have we or the colleagues that we work with been in these team meetings where we go through the thing, and anyone who's been in these kind of knows how they go. The dietitian might present, here's where the weight is, this is the trajectory, we're meeting or we aren't meeting targets, here's my justification, here's the percent I'm at from whatever goal, or hey, I want to tell everyone why I'm reassessing the goal. And often they move on. And I know that there's certainly teams that I'm on and have been on and whatever, where we give more stock to giving a little bit more than the numbers. And I think that's the way we're headed, hopefully. But we need to also get really good at our case conceptualization of where is this person in their actual healing, not where are they on my chart here or towards the number I gave insurance on week 1. But what am I observing when I bring an item of food into session? What is dad telling me about when he picks her up in the afternoon about how she's doing? Or, how is he doing as far as reports of, sleep and all the other stuff that's going on? And to not be distracted by where they are in the weight progression, or the fact that they are perhaps going continuously above every week from where we thought that initial target would be. If we're still not in our trench seeing, some improvement from the distress, we're not out of the woods yet. And I also want to take it, really to heart that any of us supporting people through their recovery, if we're really doing our jobs, we are really in the trenches with them. We're not just talking about it, we're taking opportunities to really see and understand and listen to what they're going through. And again, very rarely in my experience, and I'm going to speak for Sean here because we talk about it a lot, very rarely do we see them hit those weight targets and not be in a lot of behaviors and distress still down from the trench that we're in with them. So it's usually going to take more gain.
One thing I wanted to add with that, but Mary, you were talking from the trenches and sharing the observations, and this is maybe something we can get into in the Q&A, but I think of how for us sometimes that comes about of being, well, wait, is this perfection? Like you're wanting perfection from me. And something that I've always said to clients is like, hey, it's my job to do this, and I'm not going to sell you short. I know that if there's this much if there's this much of the eating disorder left, it's going to continue to grow. And so therefore I am going to be diligent and see and call out everything that I can call out, because I owe that to you. That is my responsibility to you, regardless of the body shape or size that you're in. We need to get your body to a place where we can see that it is happy. And I know that's very like, okay, oh, all we want is happiness. Yay, right? But like, no, we're talking about the state. And so Mary will get more into that.
Yeah, I think that, yeah, happiness, I hope, peace, I think is attainable, right? Like we say, like, you know, you may not run through the sunflower fields loving every bit of this recovery, but I hope for you peace. And I hope that when we are encountering different situations, when we're deciding whether or not to respect and nourish our bodies, that we can at least come at it with some peace. And I think that's what you're saying, is leaving no stone unturned, because we know that those stones harbor a lot that's going to keep growing if we don't get there.
I'm going to go for
I'm ready for the next slide, because I think this is an important statement. Okay. So semi-starvation and weight suppression play key roles in driving eating disorder symptoms and behaviors. And we have this so much in the literature. And I would challenge anyone to think through their cases or their loved ones, or maybe their own lived history of if they were able to reach recovery when they were still in weight suppression or semi-starvation. And I also want to say this can happen across all bodies, all sizes, all weights. So again, I hope we're speaking to the choir here, that someone's weight or body size does not tell us whether or not they are in a state of malnutrition or not, or weight suppression or not. This goes across all of it. So if you think of some key features of eating disorders, right, there's generally a lot of rigid rules, maybe, you know, certain rituals that a person might engage in. Maybe there's some binge eating patterns sort of in retaliation to those rules, as you know, restrictions being put on a person. We're generally in a real scarcity mindset when it comes to food and availability of it for ourselves. In a biological scarcity set where the body isn't trusting that it's going to have all the substrate that it needs to keep repairing and growing and recovering and making those new neural pathways that we need for recovery to really stick. So we know that no matter the body size, that any degree of dietary restriction or weight suppression is only going to keep the eating disorder alive. And I think it's really, you know, just great research that's come out. Even Dr. Cynthia Bulick at UNC Chapel Hill, one of our leading researchers, really speaking to this. This is across weights, across nutrition rehabilitation plans. You know, sometimes I'm in settings where I might be speaking to someone's meal plan, and it might be on what we would objectively call a high meal plan, but that still might be a starvation plan for someone who's going through different spaces in recovery. They might be plotted on, I'm just going to go back and say that BMI chart in one of the categories that's on the high ends of the spectrum, and they're still in weight suppression or a malnourished state. So we have to really be advocating for looking for all the markers that we're not going to get to on a calculation to tell us if this person is actually in a place where the body is trusting that it's in a fed state and that we're no longer weight suppressed. And that is a hard sell with a lot of teams. I'm just going to say we have, and I just have to say this here, just giving some love to those eating disorder dietitians. This is really, really hard work. I can't speak to the levels of fear, anxiety, tears, frustration, really from a place of compassion for the clients that come up when we're advocating for bodies, because we know what we're seeing. Sometimes we're seeing a person who is undergoing all the pressures of this world of weight stigma, and they are in a starved body. And we've got to get some allies on our team to help support that body and healing. And so I'm loving this research that is I think, at last giving us more of a voice to that. Okay. You can go on. Oh, this is a good one. Okay. So I don't know if anyone has come across the writings of Emily Boring. I think she's absolutely amazing in sharing her lived experience of her recovery journey. And I highly encourage everyone to really check her out. And so we did get her permission to talk through kind of what she shared. And Sean's going to be reading a little bit of her writing. But so this is a classic ball and cup diagram. Am I saying that right? Yes, a ball and cup diagram for science. And basically, Emily's taken this and described on the left here as the valley of the eating disorder, and on the right, the valley of recovery. And in the middle is this threshold. And if you look, it's a very, very steep climb up this hill to get from disordered to recovery. And basically what Emily shares in her speaking and writing about her own process is that she had been through treatment time and time again. She had been with various providers and teams who assessed her target weights and got her there, and she would repeatedly meet this, but she was still entrenched in her eating disorder. And it wasn't until she reached a weight and really had permission and support to do so from herself and from those around her to go over that threshold, get to a higher weight than she'd ever been to before, higher than the calculations were telling her she needed to be. And her ball went into the valley of recovery. So I think, Sean, maybe you can read for us some of Emily's writings about her experiences in these places.
I'll do it. And just so this is the reason why we're reading this is because it's very eloquent. I know that you guys can all read it, and I would encourage you to read the article. It's available on the Feast webpage. And Mary, did we put it in the references? I don't remember.
If we did. And Emily's, I have her contact info as well. She's amazing. Yes.
So anyway, so here, check this out. So Mary was just talking about when Emily got past that threshold, right? And what we talk about here at Within is the ERP, that exposure response prevention curve as well. And so when you're thinking of the fear of where that's coming, right? Like if we look at this slide, we could see, okay, the fear gets to this place of probably almost intolerable or intolerable. I just made up a word, maybe new word today. Look at that. Everybody's learning today, new words. Wonderful.
I just have to say, when my clients are going up there, I mean, what do I want to do? I want to rescue them. I want to decrease their distress. I hate seeing them so distressed. And I think I have the gift of having been in this field now long enough to know I have to hold that. I have to.
Oh. Looks like Mary froze on us, but what she was saying is we need to hold on to that. We need to hold on to that anxiety. We need to hold on to that.
And from it, I want to help them through it. I want to keep them safe and all of that, but they have to get through that. But so often in our team collaborations with various, groups, coming from a place of love and compassion, this is where people want to back away and say, it's good enough. It's good enough. I don't know that this person can tolerate more. They can tolerate more. Our clients are so strong and so resilient. We have to give them a chance at getting over to the other valley.
Cool. Nice. And so how does Emily describe that valley of recovery, right? In that valley of recovery, I feel comfortable in my body. I look in the mirror and observe the changes between my appearance now and my appearance in the illness. And I greet this difference with a symbol of life and strength. I listen to cravings. I have no trouble cooking independently, traveling, going out for meals, eating desserts. All the signals of my body, my cues for hunger, rest, movement, my mental state and thought patterns, they're in tune with my goal, and I want to say with my values of maintaining this healthy equilibrium. The valley of recovery is vivid. It's constant, a self-sustaining, holistic worldview. And I think that basically goes into what we were going to get to with state of what we're going to be talking about with that. I'm not going to, just with the likes of time, Mary, I'm going to keep the disordered one off there, but this I think can really lead into the state.
Okay, you all can read it on the Feast website by Emily, and it's called If in Doubt, Aim Higher. And that is so my guiding philosophy with weights. Just keep aiming higher. Because you're probably not there. I will just say that in the disordered realm, even though being fine on paper, it just reinforced all of the eating disorder behaviors. So can read it there. Okay.
Nice.
So we're at that state discussion, and I really, really hope that everyone attending has heard or is curious to learn more about just the idea of weight versus state, weight and state. They're both imperatively, I mean, they just go hand in hand. Like, you can't assess for weight without looking at state. And I think that big question that perhaps many of us ask our clients is, are you alive? Or are you really living? Are you living your life? When Emily talks about her experience in the Valley of Recovery, it like brings tears to my eyes, Sean, when I heard you read that, because that is everything that I want for my people, right? Like, I just want, one of my clients said it so beautifully not long ago. They said, I just want things to go back to how they were without this disorder, when I didn't give it a second thought and I had freedom and flexibility. And that's what we want. And so I think that, you know, those of us working in assisting clients kind of navigating through this process of recovery, we get to see some really cool things happen. And so often when we first meet someone, and maybe this is me speaking of working in a lot of treatment center settings where maybe we have higher acuity, but you might get this outpatient as well. You probably do. A client might come in and we always say, oh, gosh, for those first couple weeks, it's like they're just flat. Like, where is the person? And then, I don't know, I usually think about it over like 2 or 3 weeks. It's like we start to see them come alive a little bit. They might, you know, laugh at a joke. Maybe they're not cracking jokes yet, but there's a little bit coming back. It's like, wow, you've got a personality. You're a little, you know, spicy or whatever. And I know that's always met with great joy on a treating team, or when we'll talk to families, they're really excited because they're getting a glimpse of that person back. And that's a wonderful indicator, right? And we start seeing a little bit more flexibility in thoughts and things like this. And we'll see this like usually improving for quite a while, but kind of back to that ball and cup diagram, man, can we see it come full force when we let them fully, you know, get to that place of recovery and support that. But what we really want to be assessing, and I think this also goes back to our job. So your dietitians are so much more than setting and maintaining and checking up on meal plans and making sure that people are doing things that are going to help those labs and those weights and all that come to places that are more indicative of recovery. We're also going to really be assessing state throughout. So in all of our conversations with our clients, like, we have this just incredible vantage point to not only be hearing about, oh yeah, how did breakfast go? But like, tell me all about it. I want to hear everything that went on with all your decisions around it, and tell me where you practiced flexibility this week, and where did you feel stuck, and like all the things. Because what we're really assessing there is, where are they in state? You know, are they taking on challenges because they're directed by team members, or it was put in front of them by, you know, a family member, or what? Or where are they able to take on these things some more? So you can read through these indicators of state. I know, is this we're going to show them their goodie, Sean? Okay, so we've made a thing for you all to have. But these are just some things that we thought you could have. And this is a printout that you'll be able to access. And so it's just assessing these different domains, right? Of what are different markers that we're looking for. And so I want to challenge everyone working with clients, particularly dietitians, to really be assessing this constantly in your challenges with your clients, in what you're seeing, and so forth. Because this is what we've got to be bringing to meetings more and more. This is what we've got to be talking to those physicians about, who, whether or not they're supportive of the weight goal or continuing to restore past. We've got to be able to speak to all these domains of where we're seeing state improvements, or seeing states being really stuck, or maybe even kind of regressing a bit. So I am a really big fan of bringing food in wherever we can bring food in. So I really encourage anyone, no matter your setting, because I think many of us know, like, you get a very different presentation when you're talking about food versus when you're doing food. And that can be anything from meal support to, I have sometimes just had a granola bar sitting in my office. Or I know Sean's gotten very creative in the virtual setting of what you might want to bring in there. But this is all for your state assessment. Yes, it's challenging your client, but you can really, really see where are they at with these things, and really diving in those nutrition sessions to understand more about both physical, where are we at with, appetite and hunger, fullness, and all of those sorts of cues. Where are we at with agreeing to, show up at that social event where that food is going to be involved, and where are you moving away from it? If we're not showing increases in flexibility and authenticity and getting back to those kind of goals or what things would have looked like without the eating disorder, we're probably not there yet. So that's where we keep pushing. Another thing, I think a big state one that we can really work with our colleagues with in therapy is, where is the client becoming more in line, where their behaviors going more in line with their core values. I think that one that comes up so much in eating disorders is honesty, truthfulness. The eating disorder doesn't always allow for that. But when we really see the person able to make those values aligned choices when it comes to abstaining from eating disorder behaviors or disclosing urges or behaviors, that is huge. So I really want to offer giving space for, in any of our collaboration meetings for clients, family meetings or whatever it may be, that we give some minutes to where are we at in the state assessment. And so Sean and my hope is that this tool might even be used as like a check sheet that you could bring in with you to really be advocating.
Totally. And that's what I wanted to highlight too. Please, I encourage everybody involved, and even clients that are out there to check out some of these parameters, because this is where we have those hard conversations with ourselves. Like, okay, wait a sec, what's really happening right here? Like, am I, where are my interests lying, and behaviorally, emotionally, things like that. So this will be available for everyone after the presentation. So just
absolutely.
So thank you.
Yeah.
Cool. And we'll get back into it. Finishing up, y'all. So you're in the final stretch. 10 minutes, y'all.
Yeah. So where do we go from here? So I hope that people working in this feel really validated. People working through their own recovery process. I hope that in some way this speaks to having some faith in the body and knowing that it knows where it needs to lead. So I think this is a place where we can say, remember your role and remember your vantage point from those trenches with your clients. Because wherever you sit on that treatment team or in that family or whatever, you have something really important to offer of really knowing where that person might be in the state assessment. Gathering evidence. So I think that anyone who works with me knows that this is what really makes me so much, other than helping clients find recovery, makes me love what I do, because we get to have a lot of, I'm going to call it fun. I will say my clients don't usually call it fun while we're doing it, but this is when I get the nice letters and thank yous and whatever's after, because I'm not afraid of that threshold. I'm not afraid of climbing it. As long as we climb it along with our clients and support them through it and help them after, I think we can do some really hard things. Because at our core, we have to trust the wisdom of the body. And I want everyone to always come back to that. And if you're not there with your own journey in your own body, you're not going to be there in your client's body. So we all have to do a lot of work, right, to really assess where are we at in our own, understanding of our own weight biases or weight stigmas and our own worries, fears, all of that, ourselves, for our clients. We have to trust the wisdom of the body, because if I know one thing about clients with eating disorders, they can sniff out any doubt, any hesitation like no one else. And I think that's why I love this population so incredibly much. But I know Sean wants me to tell an example of some things that we might do, because we want lots of tools. So we want to do things that throw it off, right? So I am a huge fan of challenging everything we know of the behaviors that our clients might engage in, right? If they're a calorie counter and a food counter and all that, then guess what? I'm going to break up all the pretzels in the bag so that you don't have perfect configurations to put together to start testing the waters of uncertainty, right? I'm going to encourage that client to buy bread from the bakery without any labels on it and get weird shapes of things and stuff like that. Anything to just start practicing, because that's going to be my evidence that I can bring in. So I'm going to share an example of what you might be able to do. And we could really do this across different settings. I'm thinking, everyone working from outpatient to a treatment facility could maybe take bits of this to use in their own way. I will share from working in the luxury of a center setting where I can kind of see where different clients might be in different spaces. So I recently had several clients where I was really trying to just gather a state assessment, because all of these individuals were on paper they had met their initial target weights. One was past that, one was, above that, like 95%. So we're all within realm, and we're trying to really assess, gosh, are these people ready to move on? Or I was kind of suspecting one might actually need to step up to a higher level of care, because even though everything was fine on paper, I would just say, I just don't see the state moving. I just don't. And so anything we can do to throw things off. So in my setting, these clients are knowingly coming in where there's going to be at least, there's going to be a meal served, and they might know certain nights that are different challenges and things like that. And so with this particular instance, I said, let's throw a big curveball. Let's have a surprise sweet item happen, because the sweet foods caused a lot of energy and activation with this population. And so let's do that. And I really want to assess where they're at and their freedom and flexibility, their willingness to add this, if they're going to compensate, all of that. So I brought my little group in the kitchen, and surprise, I've got all the stuff out. We're going to be making some icing. We're going to be decorating little cakes. And then, big surprise, we're actually going to be having them along with our meal. Not mandatory, where in treatment center settings, a lot are, I'm not going to call them mandatory, but highly, highly encouraged. These were optional. But I think there was a lot of understanding from the clients that this was an opportunity to show their degree of flexibility. And so one, I was assessing if this person is ready to advance to outpatient from an intensive outpatient. One, I was assessing if they're appropriate to be in the level they're at. One, I'm assessing if they're actually needing to step up in levels of care. And honestly, in seeing these clients come in, one literally shook, was visibly shaking. So states not really aligned, right? The one I was, suspecting, all right, am I signing off on this moving down in levels of care? This one, honestly, I describe it as this person was so natural with the food. It felt like I had just brought in a person not struggling with any kind of disordered eating. They licked the batter, they piled it on and picked all the sprinkles that they thought were really appealing to them. And it was very naturalistic. The one that was shaking had to, kind of soothe through this, vocalize all of the thoughts going through, which I was very appreciative. It brought out the thoughts into the real space where we could talk through and reframe and talk about using skills. And then my other client was, I think, really presenting as hesitant, but slightly willing, really appropriate for the level of care that we were in. So those are the things I want to bring to my meetings, to really talk about where are these people outside of weight, because in some of those cases, I needed to advocate to continue the weight restoration. So I want to just bring those examples as things that, we might do. Other clients, again, there might not be actual meal support involved, but I'll have a little surprise thing waiting in my office. And let's just even see the comfort of sometimes a food in a wrapper that they're not even being asked to consume is highly distressing, or whatever the case may be, or changing something. Working with families. I had a family recently, who prepares the food for the client to come and eat with me. You could do this on screen as well. And then we did a last minute switch of the food item to throw things off and to be assessing in that what comes up for the client. Are they able to tolerate this last minute change, or were there, compensatory plans in place to try to throw that off? Oh, what'd you say?
No, I don't know. I thought you froze on me, so it's my internet connection. I'm sorry. I started talking.
Okay. No, I look at the time, so we're about out. But I just want to encourage everyone: do what you can to get your evidence past what you're seeing on paper, and I'll leave it at that.
Cool. Well, and it comes back to trusting the body. And I wanted to be able to, I know we're tight on time, y'all, but I just wanted to say thank you to everybody for coming and the conversation. We can have some more conversation too, specifically of what Mary was bringing up about how to assess the state, specifically even from the remote world as well, because there are things that we do with clients, like what Mary mentioned about with those challenges, is we set up things with clients and we're able to actually say, okay, hey, we're going to do something this day, but we're going to leave it up to us and we'll find out that day. Or some days we might say, okay, hey, this week we're going to have a challenge, and it might be something like that. And then also too, like Mary mentioned, bringing things into session. Hey, let's have snack together. Wait, but it's not snack time. I know, but let's have snack together. Let's do it a little earlier. So, but the main takeaway, y'all, is please trust the body. Know that you have support around you, and if you need to reach out for things, please do reach out to myself and Mary, and we're more than happy to talk. And thank you for your time, Jamie.
Thank you both, Mary and Sean. What an amazing talk. The chat is blowing up with praise and support about how much this conversation is needed and feeling validated as dietitians. We did not get an opportunity to get to some of the questions, but you guys did share your contact information. So for those of you that did have a question or a comment, please feel free to contact Mary and Sean directly. And as for the materials, we will update the handout. The handout that they shared is available, but we are going to make an update to the handout, correct, Sean?
Yes, I thank you, and thank you for your patience, y'all. Mary, as I was showing it, I saw the psychological wasn't necessarily like aligned, so I'll just
we got to make it prettier.
Yeah, that's it. Perfection, right?
That's good.
No, but I want it to be user friendly. That's the thing. I want it to be user friendly for everybody.
So we will make it prettier and we will update it, and then it will also be available in your CEGO dashboard. Again, remember, in order to get your certificate, you will need to complete the survey and you will get a link to download the certificate, and this will be available via video tomorrow. Thank you so much, and I will see you all in the next presentation. Have a wonderful day.
Thank you.
Thank you. Bye.